Now for the third and final case. This is a mass on the wrist of a 30-year-old male. At low power, we can see that this is a multinodular lesion located in the deep soft tissue. Fibrosis is seen both between and within the nodules and ranges from dense to more thin and wiry. Areas of hemorrhage can also be seen. The nodules themselves are composed of tight, hypercellular fascicles of uniform, plump spindled cells. Although the cells themselves are not particularly atypical, the marked hypercellularity along with mitotic activity is concerning. This is an example of a synovial sarcoma, a high-grade translocation-associated sarcoma that classically occurs in young adults in the deep soft tissue of the extremities, often near the joints, with the knee being the most common site. Historically, it was thought to arise from synovium due to its tendency to occur near joints. However, this has since been disproven, and the true cell of origin remains unknown. Synovial sarcoma is defined by a recurrent translocation between chromosomes X and 18, resulting in the fusion of SS18 with SSX1, 2, or 4. Immunohistochemistry is nonspecific, and there are plenty of pitfalls that I don't have time to go over because this video is long enough. There are some emerging immunohistochemical stains targeting the SS18-SSX fusion, but molecular methods remain the gold standard. If you want to learn more, I've included links to some recent papers in the video description. Clinically, this is an aggressive tumor, and distant metastases occur in about half of cases, with the lungs being the most common site. Here is an example of a lung metastasis in a different patient. In this case, the herringbone pattern is very striking. However, I must caution you that this is not unique to synovial sarcoma, and this pattern can be seen in other high-grade sarcomas. For example, this is a leiomyosarcoma, also metastatic to the lung. I remember when I saw this, I was so sure this was a synovial sarcoma, and I was really surprised when I read the history. Another high-grade sarcoma that can enter the differential is malignant peripheral nerve sheath tumor. This case has rhabdomyoblastic differentiation, so it isn't the best example. But if you ignore all the big eyeball cells, you see the same pattern of tight hypercellular fascicles you saw in synovial sarcoma and leiomyosarcoma. Infrequently in synovial sarcoma, there can be extensive degenerative changes, including cystic change, hemorrhage, fibrosis, and calcifications, especially if the patient received neoadjuvant therapy. Here is an example of a post-treatment synovial sarcoma where the calcifications are especially extensive. So far, I've only shown the most common type of synovial sarcoma, monophasic synovial sarcoma, and I am truly sad that I do not have an example of biphasic synovial sarcoma to show. As the name suggests, this type of synovial sarcoma also has a glandular component, which can range from focal to extensive, with rare cases mimicking an adenocarcinoma. And that's all I have for now. Thanks for watching, and please like and subscribe. I promise you won't have to wait as long for the next video.